Welcome to the deep dive. You're here for the essential breakdown of granulomatosis with polyangiitis, or GPA, you might remember it as Wegener's.
That's right.
Think of this as your express route through the must-knows from our revision notes. It's designed to stick.
Exactly.
Our goal is pretty simple: arm you with the key facts about GPA for exams and beyond.
Yeah, absolutely. We're hitting the high points. What GPA actually is, the main areas it hits. Remember ELK.
ELK, right.
What might cause it, how it, causes problems, how it's spotted, and crucially, how we manage it.
Okay, let's dive right in then.
Let's do it.
So basically, what is GPA?
Okay, so GPA is a rare autoimmune vasculitis. That basically means your immune system, it mistakenly attacks small to medium-sized blood vessels, causes inflammation.
Okay.
You mentioned the old name, Wegener's granulomatosis. The really crucial thing is that this inflammation tends to go for the respiratory tract, think ears, upper respiratory, and the kidneys.
The E and K in ELK.
Exactly. And on top of that, it forms granulomas. These are little clusters of inflammatory cells that can cause further tissue damage.
So when we say multi-system, it really covers a lot of ground.
Oh, absolutely. ELK is your core. Ears, upper respiratory, lungs, kidneys, those are the big ones to remember.
Lungs, the L. Got it.
Yep. But GPA isn't limited to those. It can definitely show up elsewhere. For instance, joints are affected in, quite a few patients, maybe 25 to 50%.
Wow, okay.
It can also involve the sinuses, eyes, and even the skin.
Yeah.
So that guy, it has a pretty wide reach.
Interesting. What actually sets this off? What are the potential triggers? And who's more likely to get it?
Well, the exact cause is still a bit unclear. It's likely a combination. Genetic factors and environmental influences probably work together.
Right.
We do know that autoantibodies play a big role, especially ANCA antibodies. Think of them as sort of misdirected immune signals. They're heavily involved.
ANCA, okay.
And certain environmental triggers, maybe infections, seem to be able to flip that switch in people who are already susceptible, genetically speaking.
And are there specific risk factors we should know? Things that might sort of raise a flag?
Yeah, there are several. A family history of other autoimmune conditions that can increase risk.
Makes sense.
Certain occupational exposures have been suggested too. Genetic variations definitely play a role. And interestingly, it seems more common in colder weather.
Why is that?
Well, the thinking is maybe it's linked to more frequent infections during winter months.
Okay.
And a couple of specific organisms have been linked too. Parvovirus and being a chronic carrier of Staphylococcus aureus in the nose.
Right, the nasal carriage. Okay, so this inflammation in blood vessels, what's the actual effect on the body? What kind of damage are we talking about with GPA?
So the inflammation itself damages the vessel walls,
Right.
which can restrict blood flow to organs. That's one part. But the granulomas we mentioned, those collections of immune cells, they also actively damage the tissue around them.
So it's a double hit, sort of.
Kind of, yeah. In the respiratory system, this can mean things like persistent sinusitis, nodules forming in the lungs, sometimes even cavities.
Okay.
When it hits the kidneys, it causes glomerulonephritis. That's inflammation of the kidneys' filters, which messes with their ability to clean the blood.
And the other areas.
Yeah, and like we said, eyes, skin, nerves, joints, they can all suffer from this inflammation too.
Got it. Now, if someone comes in with these kinds of symptoms, how do clinicians tell GPA, apart from other things that might look similar? What's the differential diagnosis process like?
Oh, that's a really critical step. GPA can definitely mimic other conditions, so you need a thorough differential.
Right.
You've got to consider other types of vasculitis first, things like microscopic polyangiitis or eGPA, which used to be called Trigg-Strauss.
Okay, other vasculitis.
Then there are specific diseases like anti-GBM antibody disease, maybe Legionella infection, mixed connective tissue disease, lupus.
Wow, quite a range.
Yeah, and even other ANCA-associated vasculitides need ruling out. Plus, you need to think about broader categories too, like infections, sarcoidosis, even some cancers can present vaguely similarly sometimes. It's quite a list to work through.
It really sounds like detective work. Okay, zooming in on the UK then. How common is GPA here? Who usually gets it? What do the numbers tell us?
Well, it's definitely a rare disease. The exact UK numbers are still being firmed up, but the estimate is somewhere around 110 new cases per million people each year.
So not very common.
Not at all. It's most often diagnosed in middle-aged adults, sort of peak age between 35 and 55. Though interestingly, we are seeing it diagnosed more in children than we perhaps used to. More specific UK data suggests about 8.4 cases per million per year for GPA overall.
Hmm.
And if you look just at renal vasculitis, so GPA affecting the kidneys, it's about 5.8 per million.
And is there a gender difference?
Slightly more common in men. The ratio is roughly 1.2 men to 1 woman.
Okay.
And yeah, if you have a first-degree relative, parent, sibling, child with an autoimmune or inflammatory disease, including GPA itself, your own risk is, well, modestly increased.
Okay. So what are the key clinical signs, the things that might make a doctor suspect GPA when they see a patient?
The presentation can be really varied. It totally depends on which organs are involved.
Right.
But common things include persistent sinusitis that just won't clear up, other upper respiratory symptoms, a cough, maybe even coughing up blood.
Haemoptysis, right.
Exactly. Lung nodules on imaging, kidney issues showing up in tests, joint pain, maybe skin lesions, eye inflammation.
Lots of possibilities.
Yeah, and patients might also have those more general nonspecific symptoms like fatigue, weight loss, fevers. Some more distinctive signs, though less common, could be a saddle-shaped nose deformity, a specific type of vasculitic rash, or even problems affecting the cranial nerves.
And you mentioned specific organ systems give clues.
Definitely.
Hmm.
For respiratory symptoms, think runny nose, sinusitis, facial pain, maybe hoarseness, cough, feeling short of breath, wheezing, chest pain.
Okay.
Kidney involvement is often this rapidly progressive glomerulonephritis, the Polyangiitis type that happens in about 80% of cases.
Wow, 80%.
Yeah, it's common. ENT-wise, nosebleeds, crusting inside the nose, sometimes subglottic stenosis, that's a narrowing below the vocal cords. Skin can show rashes, ulcers, nodules, eyes,
Yeah.
conjunctivitis, scleritis, episcleritis. Neurologically, you might see mononeuritis multiplex, which is damage to multiple individual peripheral nerves,
Okay.
and sometimes even abdominal pain, peritonitis. One important point, though. High blood pressure and high eosinophil counts are not typical features of GPA. That can be a helpful clue sometimes.
Good negative findings to keep in mind. So, with such a wide array of signs, how do doctors confirm the diagnosis? What are the crucial investigations?
Right, so the investigations aim to do a few things. Detect those specific antibodies we talked about, evaluate how involved the organs are, and ideally confirm the diagnosis with tissue.
Okay. Blood tests first.
Absolutely key. We're looking for CANCA that's positive in over 90% of people with GPA.
Over 90%. Wow.
Yeah, it's a strong marker. PANCA can be positive too, maybe in about 25%. Specifically, the antibody we often find with CANCA is antiproteinase 3 or anti-PR3.
Anti-PR3.
Exactly. Anti-myeloperoxidase or anti-MPO can sometimes be present too, often associated with PANCA or sometimes in GPA as well. Then you'll do general inflammation markers like FBC and ESR, and definitely check kidney function with serum UNEs.
And urine tests.
Yep, urinalysis is crucial, looking for protein, blood, and maybe casts, which are all signs of kidney inflammation.
What about imaging or other tests?
Nasal endoscopy lets the ENT docs have a look inside the nose and sinuses. Lung function tests, especially something called a flow volume loop, can help detect that subglottic stenosis.
Okay.
Chest x-ray might show abnormalities like cavities or infiltrates, but usually a chest CT scan is needed for a better look at the lung tissue itself.
More detail.
Exactly. Same for the sinuses. A sinus CT scan helps assess sinus disease. But really, the gold standard for confirmation is often a biopsy.
Taking a tissue sample.
Right. From an affected area, maybe the nasal lining, the lung, or the kidney. Under the microscope, they look for evidence of vasculitis, the vessel inflammation, and those characteristic granulomas. A kidney biopsy might show specific things like epithelial crescents and Bowman's capsule.
Right. Okay, so once GPA is diagnosed, what's the approach to managing it, particularly here in the UK?
Management is definitely a multidisciplinary effort. The main goals are, 1, induce remission, get the inflammation under control. 2, protect the organs from further damage. And 3, maintain the patient's quality of life.
Makes sense. How is that done?
Immunosuppressive medications are really the foundation. Corticosteroids, like prednisolone, are used initially to rapidly reduce inflammation and control the disease.
Standard first step.
Pretty much.
Yeah.
Then cyclophosphamide is very effective for inducing remission, works in about 90% of cases. It's often given as intravenous pulses. Rituximab is another important option. It might be considered if cyclophosphamide isn't suitable for some reason, or if someone's reached their lifetime dose limit, or if preserving fertility is a major concern.
So alternatives exist.
Yes. And once remission is achieved, you need maintenance therapy to stop it coming back. That often involves drugs like azathioprine, methotrexate, leflunomide, or mycophenolate.
Right, keep it suppressed.
Exactly. And the prednisolone is usually tapered down very slowly, generally after the patient's been in remission for at least a year. If there's severe lung or kidney involvement, the immunosuppression needs to be quite aggressive from the start.
Hmm.
And in very severe life-threatening cases, sometimes plasma exchange is used to quickly remove the harmful antibodies.
Plasma exchange, okay. What about relapses?
If a relapse happens, the usual approach is to increase the prednisolone dose again and review or optimize the maintenance immunosuppression. And sometimes you might need surgery for specific complications, things like fixing a nasal deformity, dealing with subglottic stenosis, or managing acute kidney injury if it occurs.
And you mentioned a newer treatment, Avacopan.
Yes, Avacopan. It's a more recent drug that can be used alongside the standard treatments for severe active GPA. The idea is it might help improve efficacy and potentially allow for lower steroid doses, which reduces side effects.
Ah, steroid sparing.
Potentially, yeah. Mnemonic has approved its use in certain situations in the UK.
Good to know. So, looking down the road, what's the outlook for someone diagnosed with GPA? What's the general prognosis like?
It's quite variable, honestly. It really depends on which organs are involved, how severe the disease was when it was diagnosed, and how well the person responds to the treatment.
Understandable.
The good news is that with proper management, most patients do achieve remission and can have a significantly improved quality of life.
That's positive.
It is. The first year after diagnosis can be the riskiest period, often due to potential infections from the immunosuppression, active vasculitis itself, or kidney injury. Interestingly, there seems to be a slightly unexpected peak in mortality risk around the 8-year mark too, though the reasons aren't perfectly understood. But overall, treatment advances have definitely improved the prognosis compared to decades ago. Remission rates are around 80%, which is great.
Relapses.
Relapses are common, unfortunately. Maybe about 50% of patients relapse within 8 years.
Okay, so ongoing vigilance is needed.
Absolutely. And sadly, some cases are resistant to treatment. A poor prognosis is often linked to deteriorating kidney function, or if the systemic vasculitis aspect is really dominant over the granulomatous inflammation. So long-term management is key, controlling inflammation, minimizing chronic damage, watching for related issues like malignancy risk, and managing drug side effects carefully.
Right, and what specific complications can arise from GPA itself or its treatment?
Well, from the disease, you can get acute kidney injury, potentially leading to chronic kidney disease. Lung scarring or fibrosis can develop. Hearing loss is possible. Chronic eye inflammation like conjunctivitis, and perforation of the nasal septum, that hole in the middle of the nose. And then, of course, you have the risks associated with treatment, mainly infections because the immune system is suppressed, other side effects of the immunosuppressants, and as we mentioned, disease relapses themselves are a complication.
So it sounds like early diagnosis is key.
Absolutely crucial. Early diagnosis and getting treatment started promptly really helps reduce the risk of these complications and improve the long-term outcomes.
Okay, so let's wrap this up. To bring it all together from this high-yield revision dive, what are the absolute must-remember takeaways about GPA?
I'd say, remember, GPA is an autoimmune vasculitis. Think ELK for the primary targets. Ears, upper respiratory, lungs, kidneys.
ELK, got it.
Early diagnosis relies heavily on investigations like ANCA testing, especially ANC anti-PR3, and ideally getting a biopsy.
ANCA and biopsy.
And finally, management with immunosuppressive therapies has really changed the game and significantly improved prognosis for most patients, although long-term monitoring and management are essential.
Excellent summary. And for those of you listening who are prepping for exams and want more high-yield resources like this, definitely check out passthemsra.com and also freemsra.com.
Good resources.
It's clearly a complex condition, but hopefully this breakdown of the essentials helps. Thanks for joining us for this focused deep dive into GPA.